Afternoon, everyone. Thank you so much for joining us today for the Early Childhood Learning Community. My name is Lauren Rabinowitz, and I work for Georgetown University, but am here as part of the TA network. And we are going to get started with today's learning community. While we are getting started, feel free to chat into the public chat where you are from. And yes, anytime you're having any questions or thoughts, you can feel free to put that in there into the chat and we will respond. So we are really excited about we have two presenters to talk with you all today. And as always, we want to make sure that this is a really informal time when you can hear some new information, but also have the opportunity to ask questions of the presenters and of each other. So today we are focusing on infant and early childhood mental health consultation. I'm going to give a more detailed overview of our presenters before each speaks. But very briefly, we have Catherine Wright from Minnesota, and we have Allison, but I believe she prefers Ali Lofotos from Illinois. And for those of you that have been on some of our past early childhood system of care learning community calls, you probably are familiar with what our goals are, but just want to quickly remind everyone, and for those that are new to the learning community, that this is an opportunity that we have designed to bring folks together that may have previously had a specific focus in early childhood in their system of care, or currently are working hard on early childhood, or are just really interested in early childhood. It's a very an open time that we're bringing folks together, and we've covered a range of different topics, and infant and early childhood mental health consultation has come up a few different times. We've had a presentation before looking a bit at some of the outcome data in Arkansas, and we heard from Linda De La Mata earlier this year about the connection between mental health consultation and home visiting. So we're going to show a couple other sides today. And as I said before, that this is an interactive session. Please do use the chat box for comments and questions, and we'll definitely have time for verbal Q&A as well. And so the objectives of today's session are pretty broad, but we are hoping that you all will be able to increase your knowledge about infant and early childhood mental health consultation from a systems perspective and also from a policy perspective. And as always, we're really hoping that we'll be able to engage in some peer learning to understand more about how mental health consultation can integrate into an early childhood system of care. I think you're really going to get some nice information on how this particular approach can fit so well with other early childhood initiatives. Okay, so I am going to introduce our first speaker, and then we'll have a little bit of Q&A after Catherine speaks, and then I will introduce our second speaker, and we will have more time for Q&A. And once again, anything that comes up as we're going, just go ahead and put it into the chat. So Catherine is the Minnesota Department of Human Services Early Childhood Mental Health System Coordinator. In this role, Catherine is responsible for the policy and systems work related to developing and managing an early childhood mental health system of care throughout the state. This work entails providing training throughout the state on evidence-based interventions for young children and families, also involves aligning Medicaid policy with evidence-based interventions and techniques, and integrating early childhood mental health services in agencies that are easily accessible to families. Catherine holds a doctorate in counseling psychology from the University of St. Thomas, and she's also licensed as a psychologist and a licensed professional clinical counselor. Beyond her state work, Catherine provides psychological assessments and treatment to young children and families in a clinic part-time. She's certified in many evidence-based interventions and has over 25 years of experience providing direct children's mental health services and managing children's mental health programs and systems. So you all are in for a treat to hear Catherine talk a bit about what mental health consultation is and how Minnesota has built their state system. Thank you so much, Catherine.
Thank you for having me. Hopefully you all can hear me. Yes? I'll assume that's a yes. Yes.
I hear you.
Oh, perfect. So I am going to talk a little bit about our journey and some of the things that we've been conceptualizing over the past, I want to say, 5 years. I've been working at the state of Minnesota for 8, going on my 9th year. So part of what we've been trying to do is really develop a system, statewide mental health consultation system. And so we've been really trying to figure out exactly what does that mean. We are a state that has a lot of coaching in a lot of our early childhood settings, and so we're trying to differentiate some of the work that we do. So our definition that we've been using is mental health consultation is really a mental health prevention service that's really focused on the adult's capacity to support young children in their social emotional development and to really prevent, identify or reduce mental health challenges. And we got that definition from 0 to 3, which I love because oftentimes I will just say within our state, legislators and advocates have thought that, and even folks in our childcare system thought that our job was to go in and identify children with mental health issues and then treat them. So we wanted to really kind of distinguish that this is more of a systems approach and it's absolutely prevention. Many people often ask, like, what does it include? And so within our system that we've been developing, mental health consultation is using a combination of training and reflective consultation, and I'll say that this is a definition that our advocates and legislators could understand. So we said reflective consultation was active listening, an exploration of the teacher's attitudes and beliefs about a situation, and problem solving. I'll say reflective consultation is often a word that gets thrown around there that folks outside of the early childhood system don't necessarily understand. And then we also have included some skill building to support our teachers, their supervisors, directors, aides, food service, transportation staff in our early learning environments. So this is a bit of a rundown of what we've been doing in our state. So as I said, we've been developing this system for a good 5 years. And the way that I've been working is I work at the state, and then I have 3 women who are supervisors who live in the community who are all experts in mental health consultation and have been doing it for a very long time. And so the 4 of us have been really developing the system across the state. And we've been working in partnership with our Childcare division and to make sure that we can embed the services that we're trying to develop into their system so that it can benefit their teachers, but in a number of different ways. And we've also been working very closely with the Head Start Association in Minnesota. And so for the past year, we've been piloting mental health consultation to child care centers, family child care, that are in our quality rating program. That's what the Building Quality Initiative is through Parent Aware. And initially what we were trying to do is get those sites that were interested in growing their professional development opportunities, who did not yet have star ratings but were interested in getting star ratings. We thought it would be a lovely opportunity for them to start to build their competency and skills to get their stars. What we found out early is that those folks that are just in the process of getting their star ratings were really stressed. They have a ton of coaches coming in, and so we expanded it to anybody in the system who was trying to get a higher number of stars or just build their quality in the star rating system. Part of what we did in our system development is really link it to our quality rating system. So all of the trainings we provide and all of the consultation hours we provide in childcare those that are participating with us in the childcare system are getting credit to move up the career ladder. So it had kind of a double benefit for staff. They were getting more competence in early childhood mental health, but they were also getting credit for it. And we've also been having conversations across our state about how to include it in our Part C system. And Part C in the state of Minnesota is run by the Department of Education, and it is seen as like an early childhood special education service. And then when we were also interested in public health and home visiting as well. And those conversations are just starting at our state. part of what I really love to talk about, and I should say a lot of these slides were developed into a two-pager for our legislators so they could better understand what we were trying to do. So we like to cite a lot of research in all things that we do so that advocates and those interested in the services or who might not even know about them would be interested in better funding us and supporting us. So part of what we know from the research, and this is recent research, is that certainly mental health consultation can reduce staff stress and turnover in child-serving agencies. That is a really large issue in Minnesota. I'm sure it's a large issue across the nation. There was a recent study that Walter Gilliam and his team did. They did a randomized clinical control trial where they were actually using early childhood mental health assessment tools pre and post to see if the symptoms went down without ever intervening on the children. And it actually had significant results where there were a decrease in mental health symptoms in young children. And I'd say read that article if you haven't read it. It's wonderful. It can also reduce the educational disparities experienced by children of color. I think this is a big issue across the nation, but certainly in Minnesota where we are ranked number 50 in educational disparities for our Latino children graduating from high school. So it's something that's been understood and needs to be addressed, and we're trying to address it from an early childhood lens. Many of you know that it can reduce the expulsion of children from childcare and early learning, and it can really also increase early learning staff's competence in addressing trauma, adversity, in early childhood and family mental health conditions. And actually the origins of mental health consultation were for that purpose, knowing that there were never enough mental health professionals out there to serve all young children that needed, or children even in school age that needed service. And so building the capacity amongst those that are already holding or supporting those children made sense. So just a couple things that we've been doing in our state to make this of interest for our legislature is we did a I'll say a non-scientific return on investment study. So it's not of super high quality as far as research is concerned. But one of the things that I did is I asked, we have a number of preschool day treatment programs across our state that bill Medicaid to provide clinical services to children who are really struggling. Those services are provided 5 days a week, 3 hours a day. And these are children who are getting, who are dysregulated in many systems. And what we found with just 68 children, it cost us $5 million in 1 year. And with those 68 children, we have many more children in preschool day treatment, but 68 of those children that were in preschool day treatment had been expelled from childcare. So day treatment costs in the state about $75,000 per year per child. And what we were wanting to show is that mental health consultation, so we just did our first year pilot, it could have really prevented that, knowing that the data is showing that mental health consultation can prevent expulsion from childcare. And what we did in our pilot is we've already served about 50 sites, family child care and child care centers, and we already served 1,200 children in 1 year. And so just looking, and we know that the cost of mental health consultation in our state is what we budgeted for is about $1 million a year to serve 1,200 children as opposed to $5 million a year to serve 68 children. That was our little unscientific return on investment. Just a little bit of information about who our mental health consultants are is they are all licensed mental health professionals who are under contract. Their agencies are under contract with me. We have 44 of them throughout the state. They all hold expertise in early development, early childhood mental health, relationship building, and motivational interviewing. And many people have often asked me, like, what kind of training do you look for when people are applying? We have a whole application process. And the first things that we need to make sure is that we use the DC 0 to 3 and now the DC 0 to 5 throughout our entire state. And so we want you to have training in that. We want you to have training in our early childhood mental health outcomes. And then we also want you to have experience working with young children and families, knowing that all of the early childhood mental health services we provide in the state are dyadic with the parent and the child together. So meaning that you have a lot of training in holding more than one perspective. And then the other thing that we did is we made sure that all of our consultants were considered expert trainers in our quality rating system. And to become an expert trainer in that system, all of our consultants, including myself and the 3 supervisors, had to take an additional course, 40 hours on adult training, mostly because that system wasn't made for mental health professionals. It was really made for childcare. And so what we decided to do is absolutely we will jump through the hoops that we need to ensure that the childcare providers we serve are getting credit for the work that we're trying to support them in. So this is where our consultants are at, and you can see all of the agencies that I have under contract with me, and they serve actually all 87 of our counties and 2 of our tribal nations. So the way that we built our system is that we were using 3 big pieces of literature and system building. So we were using the What Works through Georgetown University. We were using Khadijah Johnston's book on mental health consultation and childcare. We actually, prior to starting mental health consultation, we had all of our consultants go through a book club, chapter by chapter, on her book that was facilitated by our supervisors. Part of what we find is that we ask people to read books and they don't, and so we made sure that we had a process for that to make sure that they were reading and understanding what the system would look like. And then we also use the state of Louisiana's mental health consultation model. They are similar in population size to Minnesota, and the cost of their system was about $1 million a year. And they're also broken out into, I think it was 11 or 12 regions, and we have 11 regions in our state. So the match seemed like a good fit. And their consultation included both training and mental health consultation. A couple other things that we did prior to starting is we actually talked to Walter Gilliam to ask what kind of outcome measures would be helpful for our system. We wanted to do a pre and post to find out if our consultation services were effective. And he recommended 2. One of them is the preschool expulsion risk measure, which I don't know if folks have seen that before, but it is a measure that's only 12 questions. And it helps to evaluate a teacher's perspective about kicking out children or expelling children. And so I gave you an example of like one of the questions looks like. And then we also are using the child care worker job stress inventory, which looks at how teachers, both family child care and center-based, are feeling about their job stress as we are trying to impact staff turnover. I've heard recently, I just saw him speak a couple of weeks ago, and he has a new measure that is also looking at implicit bias, which I don't think it's open to the public yet, but that's something we might also be investigating using in our state pre and post as well, because that is certainly one of the goals we have, is to reduce implicit bias in our state and child serving agencies. So we had baseline data that we got about a year ago, and this is from 86 different teachers. We're in the process, we're finishing up our first year pilot, so we're getting our second data right now. But you can look at the slide, and I'll say you will get copies of the slides if you want them. I think you can download them later. You can see the difference. Family child care has significantly more stressful job demands. A lot of it is around kind of their role. Are they a teacher or a parent or both, and then having to use their own resources for the services they're providing. Child care center staff are really struggling about control over when events happen. And certainly family child care is really struggling with how do they take time for themselves. I think what's fascinating is the Walter Gilliam measure around expulsion identified a couple of very interesting findings, is that in our child care centers, about 29% of the teachers who filled that out were on the verge of expelling a child based on his measure, which is really high. That's like 30% of teachers. And family child care and Head Start are still struggling as well, about 20% of family child care and 20% of Head Start centers. And I will say I worked at Head Start for 8 years as a manager there, and I know we had a policy about never expelling kids. And I think it happens anyway. It's all in the frame about how teachers are presenting information to families about it not being a good fit. I will also say clinically, I serve a number of children with mental health needs, and when I've had children be asked to leave a child care center, they often, almost 100%, go to family child care. usually because it's a smaller group, and then the parent has more of a relationship with the child care provider. So it's just things that we've kind of learned through anecdotes, but then are kind of seeing it more in our data as well. A couple of things that our legislators and advocates asked us for were stories. They said your data is awesome, but oftentimes legislators really don't care. They want a story. So we gave them both. So this particular story, there's two pieces here. Is one, a child care provider did state that they didn't think they'd still be working there if they didn't get mental health consultation. And these are real stories from our past year pilot. Another story, so the next three bullets are all together, is the center director was thinking, well, actually had to demote a staff because of licensing changes. And that staff felt very demoralized and was struggling with her new teacher. And the director was thinking they might have to discipline that staff person. And mental health consultation really helped to support that director in thinking about different ways of approaching the staff person, acknowledging that that staff person was really stressed and sad she lost her job. And how do we use her skills to better support everybody, because she had a lot of skills. And so part of what the director did is then ask the teacher, that particular teacher, for input on a challenging preschooler. And the teacher felt really supported again and was able to offer some great suggestions which better supported that child, and then also she was better able to support what was going on in the room that she was placed in. And I will say anecdotally again, we are going to really learn from our data, but anecdotally we're finding that a lot of our mental health consultation with our child care centers is really the directors are taking us up on it quite a bit more than the teachers need, which I think makes a lot of sense. We're better supporting the directors so that they can better support their staff. And then one of our advocates absolutely wanted a child story. And so we were able to get one where a child was getting ready to be expelled from her class because she was running out of the classroom. The mental health consultant was brought in, and the way we do any kind of work around individual children is we absolutely have to have the parent's permission first. So the consultant asked if there could be a meeting with the parent in the child care center. And at that meeting, the parent was able to reveal that, yes, the child had a trauma history, and yes, she had been negatively, the family had been negatively impacted by systems, and so she wasn't really willing to talk about that information without feeling supported and held. As a result of all of that, the child was able to get some more services. The team better understood what to do with that child because they were able to make a plan with the parent and the mental health consultant, and the parent felt supported. So what's lovely about that and how we've been using mental health consultation is it absolutely impacts more than the teacher and absolutely impacts more than the child. It can impact the whole family system. And just a couple other thoughts. We, as a state, so many states have been in trouble and possibly sued because of restrictive environments in their various residential settings. And in Minnesota, that happened to us as well. And so we wrote, we call it our Olmstead Plan, but our Olmstead Plan is much more for residential settings. It was for all settings that are publicly funded. And one of the thoughts that we had as mental health consultation would be a lovely way of training child cares and Head Starts and early learning settings on trauma and resilience. And so we've written mental health consultation into our Olmstead Plan. The way we're paying for our pilot is through our federal mental health block grant dollars, but it's not sustainable. So that's part of the issue is we're trying to get sustainable funding through our legislature at the state. A couple other pieces. All of our consultants receive monthly reflective supervision from those 3 contracted supervisors I talked about. And then all of those supervisors receive monthly reflective supervision from Khadijah Johnston. And we're also working with an agency called the Center for Social Inclusion to really work on issues of implicit bias and racism. And the way we're doing that is the Center for Social Inclusion is providing regular consultation to myself and the 3 supervisors who then are bringing it out to the consultants, who then, of course, are bringing it out to the child care sites. A couple other things is that we are one of those 3-year technical assistant grantees. through the Center of Excellence. And we are also in the process of replicating Walter Gilliam's 2005 study to really learn about who's being expelled in Minnesota. And we're hopefully going to have data from that in January so we can bring it to our legislature. I will say getting funding for mental health consultation has been a challenge in this state. It's been in front of our legislature 3 years in a row, and it hasn't gotten funded yet. So we're always hopeful and keep on plugging away, but it is extremely hard work and rather frustrating. So I just wanted to say that aloud. So that's it. That's what I have to present, and then the rest are references. So I don't know if there are any questions.
Thank you so much, Catherine. Questions, comments, thoughts for Catherine? I mean, you touched on so many different aspects, not just of what mental health consultation is, but how it fits in with that larger system and all the different connections. I really like the way your team did that calculation about the return on investment. I think that's powerful, and all your stories, those were extremely powerful as well. I see that Amy is typing in a comment, and Tiara, phones are muted right now, correct?
Yes, all of the lines are muted.
Okay, so you can go ahead and just enter a question in if you have one, and then we'll open the lines at the end. And we'll give Amy just a minute, and if not, we can, oh, let's see. So Amy asks that, she said, you mentioned all the consultants are licensed mental health professionals, and she's wondering what level of education that requires.
Yep, in Minnesota, 3 of our licensing boards require a master's degree. So we are, and then psychology requires a doctorate degree. I'll say we have, I think we have 2 psychologists, a number of clinical counselors, a number of marriage and family therapists, and a number of clinical social workers.
Thank you. Okay, and Christy is asking if you could please doing the research on implicit bias.
So nationally, Walter Gilliam just published a couple of articles, I think he published them, or you can just Google him and find his references on implicit bias in childcare. The state of Arizona did a longitudinal study on mental health consultation, and theirs was identifying how mental health consultation changed the developmental trajectory of kids of color without ever intervening on the children. So there's some studies that are happening there as well. What we are trying to do, and I should say Walter Gilliam just came up with a measure that includes implicit bias. Maybe that was your question. And I just saw him present on it like a week or 2 ago, and so I'm going to find out more from him. I think he's trying to get it published and find out where he's at in that process, because if that's a measure that we could use pre and post, implicit bias is a tricky one to measure, and we're not, his last study used an eye gaze. We're never going to be able to do that in here. But if there's a measure that we could use that a teacher could fill out, we'd be interested in that. Let's see.
Absolutely.
So the
And Elizabeth,
yep.
Go ahead.
So Elizabeth had asked how much time would a consultant spend at a child care center? Do they serve one site or several sites? So that is such a good question. So in our pilot, what I could afford was 100 hours per consultant. And part of what we had envisioned, I always envision things and then they don't quite turn out the way you had thought, right? So child care centers, usually consultants would be assigned to one, just child care centers, and assuming that they would take up that 100 hours. Based on all of the literature I could find, and even that randomized clinical control trial of Walter Gilliam's, they have a very short timeline, but they're in there about 100 hours. So it looked like about 100 hours would make sense. It's about 2 hours a week for a year. What we found with family child care is our vision for them is to have a mental health consultant have like 3 or 4 family child cares in the similar location, and maybe provide consultation to them as a team, like after hours or on weekends, because obviously they're with kids all day. We didn't quite get our referrals. We actually have one site that just signed up for that. But family child care is looking like they need about 25 hours total during the course of the year. Our program, kind of based similar to what Louisiana was doing, is about a year long.
That's really helpful. And Catherine, before you jump to the next question, I just want to comment. So, and this is Lauren, so I'm with the TA Network, but I also am part of the Center of Excellence on Infant and Early Childhood Mental Health Consultation. And just to comment that this idea about, this kind of continuing challenge and nuance to figure out of how many hours consultants should be in centers, visiting, whatever the environment is in which the consultant is operating. There's a lot of variability across the country of how different sites are doing this work. So part of it, the Center of Excellence, is kind of working to try and get a handle on that. It's not a one size fits all, but there might be some best practices. So that's really helpful, Catherine, to hear how you all determined what might work best for your pilot.
Yeah. So one of the questions I see is like, how do we pay for the training? So the training for the consultants, so here's what I figured out for each of them is we pay for them to actually provide consultation services at about $130 an hour. And the reason for that is we don't pay for seat time in the car, and so it's a higher rate so they don't lose productivity at their agency, because mental health professionals only get paid per hour, kind of like a lawyer. So that's how we figured out their pay for actually doing consultation. We also pay them for their training, to get trained, and also to sit and participate in reflective consultation themselves or supervision. And we pay that at about $100 an hour. And so that is all a part of the package. It costs us about, per consultant, with them providing 100 hours of consultation a year, it's about $17,000 per person. So these are folks that are part-time, they're doing consultation, and the other part of their time is doing clinical work for young kids. We're keeping their feet in both worlds. So we don't pay for anybody's full salary. I hope that helps. And we figured out some of those, like payment per hour, based on what our Medicaid rates are for like an hour-long session versus like a 50-minute session for psychotherapy. And then there was a question about how to access that implicit bias tool. I don't know yet. So maybe we should all just go knock on Walter Gilliam's door and say, when are you ready to share your tool? That would be, I don't think it's not been released yet, but I believe he's in the process of trying to get it published.
While you were chatting, Catherine, I was doing some Google searching, trying to get the answer, and yeah, I think you're right. We're not quite sure yet. Yes, I like the idea of us all going and knocking on Walter.
You got Walter's door. No, hello. We would love your tool.
Absolutely, absolutely. Well, Catherine, thank you so much, and everyone, Catherine will be staying on with us while we transition to Allie's. So, if there's questions that come up through Allie's presentation or later on, Catherine will still be here. But let's transition over now to Allie Lowe Photos, and so I'm going to give a quick introduction for Allie. So let me just click through the slides. Okay, so Allie Lowe Photos is a policy manager with the Ounce of Prevention Fund. So there, she works on mental health, special education, early childhood expulsion, child welfare and juvenile justice, and workforce development initiatives and issues at the Ounce. She's previously worked in direct practice in early childhood education programs, providing case management, family support, therapy with children and families, infant and early childhood mental health consultation. She's also done work supervising a teen parent home visiting program. She has international experience working in programs and projects in China, Mexico, and Turkey. Allie has a BS in psychology from the University of North Carolina at Chapel Hill and an MSW from Loyola University in Chicago. And so Allie is going to give us a sort of a different side of mental health consultation. She's going to talk some about her experience in direct practice as a mental health consultant and working in that world, and then she's moved to this policy and advocacy world at the OUNCE. So she's going to talk some about how she's leveraged that clinical work in her role now. So Allie, take it away.
Great. Thanks so much, Lauren. Can everyone hear me fine?
Yep.
Okay. That was a great introduction, and I'm happy to be co-presenting with Catherine, and I feel like my talk kind of dovetails very well with hers because so much of what we're working on here in Illinois is very similar to what she's doing in Minnesota, so I'm glad that we're presenting together. At the OUNCE, I just wanted to throw up a little bit about our mission statement and kind of who we are and what we do. We really consider our multidisciplinary strategy kind of our go-to. We have kind of 4 arms that really overlap. We've got our research department that does research studies and looks at best practice. We've got our programs that we fund. So we have a school here in Chicago called Childcare and an Childcare learning network that's across the country. We fund home visiting and doula programs. We are a grantee for Head Start and Early Head Start. And so those are our direct programs. And then we have our Professional Development Institute, which provides a lot of training for the workforce, like both center-based and home visiting. And then we have My Shop, which is the Policy and Advocacy Department, and we're a pretty large, robust team. We have an Illinois policy team that I'm on. We have a national policy team that does consulting with other states, and then we work with our partners, the First 5 Years Fund in D.C., who look at federal legislation and advocacy. And so as Lauren said, I'm going to talk a little bit about just my personal experience. So I started in direct practice. I first moved to Chicago to get my MSW, and so my background is in clinical social work. I'm an LCSW. And I've always worked at nonprofits in the city. I started at Action for Children processing paperwork for their Childcare assistant program. And then I moved to the Carol Robertson Center, which was an early childhood center, and I did family support work and classroom and individual observations there. And so this model was pretty much the Head Start, Early Head Start model, which basically requires programs to contract with a mental health consultant. And while I was a full-time employee there at the agency, my role was kind of a mix of kind of case management, family support work, and then the mental health consultation. And that Head Start model is it's not direct services to kids or families. It's the classroom and individual observations and some short-term consultation work with kids and families before you refer them out. So I worked there for a few years and then went to another early childhood program, Christopher House, where I was an embedded social worker there as a full-time employee of the agency. And that agency was really lucky in that the social work department was really diversely funded. We had 3 full-time social workers who did mental health consultation to the staff, but also we could provide direct services to kids and families because we got a lot of different funding streams that covered the social workers' salaries. And so there are some philosophical debates kind of in the mental health world on if you can do both consultation and direct practice with the kids and families at an agency. For me, I think that this is actually the best model because it meets the kids and families where they're at, and I'll talk a little bit later about one of the challenges being, referring kids out for services, and even if you are able to refer them out, can they actually connect to services? So I feel like that Christopher House model was really great, and that a clinician can do both. They can consult with the program and the staff, but also provide direct services for the families. I think it just probably requires a different kind of support, in particular, really good reflective supervision and kind of talking about your different roles and your different hats and boundaries. While I was at Christopher House, kind of talking about some of the challenges, I think, like I said, we're still just operating in silos so much. I was there as a mental health consultant, but there could be a child who was getting, early intervention services or special education services, and just the coordination was really difficult and the communication was really challenging. And then I would also say just the actual services for the kids and families. The teachers would often say, you know, I just don't even bother referring to early intervention or special education for social emotional concerns because they either won't qualify or they're not going to get services, or even if they do, the minutes are going to be really low. And so actually finding services for those kids with specific social, emotional, or mental health concerns is really important, and that was a challenge. Some of my successes while I was there, just to kind of talk about why having an embedded person there is so important, is that, for instance, I had one child who, she was 3 years old and her mother had a miscarriage, and they just had a really difficult time processing it as a family. The mother had her own mental health concerns and was processing her grief and wasn't able to process it as much with the 3-year-old, but the 3-year-old was very perceptive, really in tune with her mom, and so took on a lot of that and was having kind of a challenge in the classroom. She wasn't externalizing any challenging behavior, but she was just withdrawing, and she would make a lot of comments that kind of unnerved the staff and made them sad. And so I was able to not only consult with the staff about how to work with this child, but I also talked to the mom and did some consultations with her, and she agreed to letting the child have some individual play sessions with me that could, you know, help her process her grief where her mom couldn't always do that with her. And so if you think in the context of, you know, would this child have been referred out to early intervention? Probably not, and that probably wouldn't, they probably wouldn't have been able to serve that child or that family within that system. But having me there as the social worker, the whole family was able to get services, and, you know, they didn't continue forever. It was, you know, we gauged it by what they needed, and she did really well. So that was one example of how that kind of embedded social worker really helped in that center. I also had another success of a family where the teachers had to make a call to our child welfare, so the DCFS hotline. And best practice is to talk to that family before you make the call, which I've had supervisors say, "Are you crazy? Don't do that." And of course, you gauge it by the safety of the situation. But we actually, as a team with the teacher and myself, spoke to the mom before we made the call. We're able to make the call all together, and then also while the investigation was going on, I worked with that family to do some individual kind of play sessions with the child, but also some joint sessions with the family. And so that's another kind of example of how the embedded social worker really helped. Throughout all of this, my agency provided not only administrative supervision with my administrative supervisor, but clinical supervision from an outside source. And so, like I said, I think to be able to do all of those different parts and components does require a lot of support for the actual clinician and consultant. And so after I was the embedded social worker at Christopher House for a while, I was eventually promoted to supervising a teen parent home visiting program, which was also at the agency. And there I got a lot of experience doing kind of program administration, supervising staff, providing my own reflective supervision to the staff, and, you know, getting experience in kind of funding and enrollment and outcomes and all of those things. And so I did that for a few years, and then had an opportunity to apply for this policy position at the OUNCE. And I'd always had a close relationship with the OUNCE because our teen parent home visiting program at Christopher House was funded by them, so I knew of the organization and knew of all the great work they did and had attended a lot of trainings there. And I had always kind of wanted my career to move from micro to macro, and so I thought the timing was just right to kind of make that switch. And I really feel like my direct clinical work has really helped inform all of my policy work. I don't think I could do as effective of a job in my policy work if I didn't kind of have some of that experience on the ground. And so the OUNCE has a pretty robust policy team. We started with our Illinois policy team and then started moving into consultation work with other states and forming the Educare Learning Network with our national policy team. And then again, I mentioned our federal arm, which is the First 5 Years Fund. And we engage everyone in our policy work. We engage families, practitioners, policymakers, the general public. I talked about our multidisciplinary strategy at the beginning and how all of our departments just really work together to kind of create this cycle of best practice where, in my policy work, I regularly get the feedback from our programs, from our staff, from our training institute, from our research department, and then our policy work also filters down to all of them. We regularly give them updates. We, kind of ask them for feedback on how things might look on the ground. We engage them in our advocacy efforts and utilize a lot of our staff and programs when we're having to kind of advocate at a statewide and national level. And so it's interesting. Because of my clinical background, I focus on mostly our mental health work. And on our policy team, we're a pretty diverse group, especially our Illinois policy team. We're a mix of people from direct practice, but also people from public policy backgrounds. We have lawyers, and we're really collaborative and work together, and I think it's a good mix of of making sure that all of our perspectives are kind of working together. We find ourselves kind of in everything. While we're an early childhood education organization, as you all know, in the prenatal to age 5 sphere, that child doesn't live in a bubble. This age range is all about attachment and relationships, and so anything that happens to that family happens to that child. And so we really insert ourselves into pretty much any topic we can think of: health, mental health, child welfare, homelessness, the judicial system, community violence prevention, incarceration, pretty much anything, because basically infant and early childhood mental health and early childhood education, that's impacted by all of these things. And so I just wanted to kind of go over some specific examples of the work and projects that I do here at the OUNCE. One of the first things when I came to the OUNCE 3 years ago that I participated in was an infant early childhood mental health convening organized by the Irving Harris Foundation here in Chicago. It was held over 2 days with over 200 stakeholders in Illinois participating. And what came out of it was this report about infusing infant and early childhood. It's basically an action plan. And different goals emerged in a few categories. And those goals were in program access and availability, workforce development, funding and finance, public awareness and education, and system governance and implementation. And one of the things that kind of emerged from this report as what was considered kind of a low-hanging fruit was mental health consultation. And so this is actually pretty similar to what Catherine was talking about in her work in Minnesota. So in Illinois, we've had consultation available in a few of our systems for many years. So it's very well established in home visiting. We have it in childcare, and then, of course, there's the Head Start, early Head Start model. And then to a lesser degree, we've had it some in early intervention, and in years past, we've had it in state-funded pre-K. But here in Illinois, it's very siloed in all of those systems, and it's implemented very differently across all the systems. And so throughout the development of this action plan from the Harris convening, there was really strong consensus with all the stakeholders that consultation was an effective and necessary strategy to improve mental health outcomes for kids and families. And so basically the Harris Foundation determined that the timing was right to design a best practice infant and early childhood mental health consultation model and a workforce development plan, and they identified the Illinois Children's Mental Health Illinois Children's Mental Health Partnership as a natural leader to spearhead this initiative. So the Harris Foundation, what came out of that plan, they actually funded this and kind of launched this consultation initiative that's being coordinated and led by the Children's Mental Health Partnership. And so I serve as project coordinator right now of the effort, but it involves many, many public and private stakeholders. And the project is a multi-year expansion initiative that advances the goal of a universal, effective, and sustainable infant and early childhood mental health consultation model in Illinois with an expanded qualified workforce. And so phase 1, which was the planning phase, began in September of 2015. And during that phase, we conducted a scan of the infant and early childhood mental health workforce to assess the readiness of the workforce across systems to provide increased services. We basically tried to find out how many consultants we have in the state, who considers themselves a consultant, what qualifications do they have, what roles do they have, what do they consider the tasks, what systems do they work in, and we have a report about that workforce scan. We also developed a leadership team for the initiative of public and private partners to provide strategic oversight and guidance, and also explore opportunities to collaborate and align resources that would support consultation in their systems. We developed a shared vision and an articulation of a model of consultation that would be flexible enough to work in multiple systems, better support caregivers, and ultimately lead to better outcomes for young children and families. We didn't want to reinvent the wheel. There's already a lot of really good model and competencies out there, and we built on pretty much the same work that Minnesota has built on, the work out of Georgetown and Deborah Perry and What Works, the SAMHSA Center of Excellence, Head Start, Early Head Start. We really just kind of made it a little more specific to Illinois. And then phase 2 of the initiative started in May of 2016, and during that phase we finalized the model, which included agreed upon core competencies. So no matter what system you're working in, whether that be early intervention, childcare, home visiting, are there core competencies that are the same across all systems? We also created a workforce development plan that would support the current workforce, but also create pathways for expansion of a diverse and qualified workforce. We conducted a process evaluation of the initiative, and we created and finalized a pilot evaluation design, which will begin phase 3 of the initiative. And phase 3 began in October of this year, and that is the actual piloting of the model and the evaluation of the model, and that will be in different communities across the state, both rural and urban. And so we're basically trying to get down to kind of trying to answer some of those same questions that were raised earlier in this presentation. You know, what are the outcomes not only for staff but for kids and families as far as mental health consultation, and then trying to get down to what are the appropriate dosages of consultation, interventions, amount of time, salaries, all of that. So we're actually trying to test out the things that we've designed here in Illinois. As Catherine also mentioned, we're also trying to expand into other systems. So I told you that in Illinois, consultation has been well established in home visiting, childcare, Head Start, and Early Head Start. But so we're not only wanting to strengthen and increase home visiting or consultation within those systems, but also expand into other systems that don't currently have it. And so in our leadership team, we do have representation from pretty much all of our state agencies, and we're trying to kind of create innovative relationships and partnerships and ideas within, child welfare and also our departments of public health. And so while I love working on this consultation initiative, and mental health consultation is really great, and in Illinois we've received a lot of support for it, I do still kind of consider it an initial first step, and I'm not saying that that's easy. Consultation and all this huge project, it is very huge and challenging. But I still think that we need to have a both-and conversation where we're talking about not only consultation to the programs and the staff, but we also need the actual services for the kids and families. And so it can't just be one or the other. It has to be both, because programs still struggle with, that's great and I love consultation, but I also need to get actual services for the kids and the families. And a lot of that involves meeting the families where they're at, and kind of having mental health services in more non-traditional settings, particularly within home visiting and child care programs. And so in Illinois, we're trying to think of that. We're working really hard on the consultation piece, but we're also trying to advocate for actual services, and doing this by partnering with our Medicaid and our HFS partners to talk about, billing and services within those sectors. We also were able to insert some mental health, infant and early childhood mental health into our 1115 waiver application, and we're waiting to see if that'll be approved. So those are just some of the examples of things that we're trying to do on that front. Here at the OUNCE, I'm also, part of my role in kind of the mental health advocacy world is that I'm on the board for our Illinois Association for Infant Mental Health, and I'm the chair of the Policy and Advocacy Committee. So our association was established in 1982, and we have a really diverse range of members, close to 300, and we come from the fields of education, social work, psychology, medicine, higher ed, public policy, child development, physical and occupational therapy, lots of allied disciplines. And so the purpose of the Policy and Advocacy Committee on the association is to educate and engage the infant mental health membership in early childhood mental health policy and advocacy. And so I do a lot of distributing information through our listserv, our newsletter, our website. We have an annual conference where I do a lot of policy and advocacy updates, and then our spring seminar series. We also have chapters that I regularly present updates to about what's going on in the policy and advocacy landscape related to infant and early childhood mental health. Some examples of some of the things we did this year as a committee. So last year we actually worked with 0 to 3 to try to advocate for getting infant mental health language added into the 21st Century Cures Act. 0 to 3 had contacted a lot of us here in Illinois because our Senator Kirk at the time he was a key member of one of the committees that this legislation was in, and so we kind of rallied as a state and contacted Senator Kirk's office and advocated for getting this language into the 21st Century Cures Act bill. Also within the state, within our Medicaid, our Rule 132, which are the procedures around mental health services in Medicaid in Illinois, those rules are actually in the process of being revised, and so we've been able to, as an association, make comments on those and try to have them a little more infant early childhood friendly. Those comments were received. We haven't heard or seen if they've been accepted yet, so we're still waiting for those to be posted, the next draft to be posted. Another thing that we did this year, I don't know how many of you know Illinois, but for the past 3 years we've had no budget. This year was finally the first year in 3 years that our legislature passed a budget, so we had a huge budget crisis for a few years, and so the association and lots of other advocate organizations drafted letters throughout those years to the legislature and the governor and made lots of phone calls to advocate for a budget. I mentioned also that we made comments on the 1115 waiver application and tried to get more infant and early childhood mental health written into that. As a committee, we also wrote and disseminated a statement letter on changes in the political climate in the federal administration, just to indicate to our membership kind of where we stand when we're serving immigrant and refugee populations. And then another thing that I do is I try to get infant mental health experts on statewide committees and testify at public hearings. So, for instance, recently our Illinois State Board of Education had a panel on kindergarten transitions, and so we were able to get about 4 or 5 experts from our membership on this panel to talk about infant and early childhood mental health and how that relates to the transition from early childhood programs to kindergarten programs. And then finally, the last big thing I want to mention that I've worked on for the past 2 years, it's been my really big project, is to help draft and get legislation passed in Illinois to prohibit early childhood expulsion. So Catherine has talked a lot about Walter Gilliam's study and how it's a huge issue and how preschoolers are 3 times more likely to be expelled than their K-12 counterparts, and that it's most likely boys of color who are being expelled. But here in Chicago, too, we also have previous research from 2002 that showed a high rate of expulsion in childcare programs in the city, particularly with infants and toddlers. So over 40% of childcare programs asked a child to leave because of social, emotional, and behavioral problems, and the most challenging behaviors they listed were things like biting, hitting, and aggressive behavior. And if any of you know infants and toddlers, you know that's pretty developmentally appropriate, but these kids were still getting kicked out of their programs. So in Illinois, based on a lot of this research, we really wanted to, Chicago Public Schools in 2014 revised their code of conduct to prohibit zero tolerance policies and prohibited expulsion of preschool through 2nd grade. And then we also had a statewide law in 2014 that, again, prohibited zero tolerance policies. But our early childhood community felt like these 2 pieces of legislation, they were great, but they didn't go far enough to address early childhood, and in particular to address every sector of the early childhood system. And so we really wanted to draft some language specific to early childhood. And so I started the legislation really based off a lot of best practices and including the Head Start performance standards. because Head Start has never condoned expulsion, and they have a lot of really good language in their revised performance standards. And so I started drafting the legislation 2 years ago. We circulated it with all of our advocate organization partners. We revised it. We talked to programs. We talked to families. We talked to the Association for the Illinois Association of Education of Young Children. We talked to all the state agencies. We talked to school management groups. We presented at conferences. We really wanted to get as much feedback as possible into our language, and we revised it before we introduced it. And so we found a lead sponsor in both the House and the Senate and tons of co-sponsors, and it passed both of those chambers before the end of the session in May, and then it was sent to the governor, and he signed it into law in August. So we now have a law specific to early childhood programs that are receiving state-funded early childhood block grant funds, and then it also encompasses licensed child care programs. So it's actually being written into our child care licensing rules. So that makes it pretty groundbreaking. Another thing that makes it pretty groundbreaking is that it specifically requests that implicit bias and reflection be addressed within the professional development of the staff. And so we're really proud of it. But I hate to say now that the hard part is actually beginning. I hate to say that the easy part was getting the legislation passed, because it wasn't easy, and we actually put a lot of work into it, but now the hard part of implementation is the truly hard part, and this is where kind of the policy people can't stop advocating. We need to make sure we're still working with the state agencies as they develop the rules on how they're going to monitor it. The legislation also highlights mental health consultation within that, and having programs utilize all of those resources, and so being able to advocate that this is all being utilized effectively. Are there enough resources? Do we need additional funding? Do we need additional training, professional development? And so continuing to monitor the implementation and kind of tailoring our response and advocating for more things and going to different agencies and trying to get more funding. So those are just some examples of things that I've done. I don't know if anyone has any questions for me.
And Tiara, why don't we open the lines? So you're welcome to chat in, but you can also, if we can open the lines up, we can definitely do some Q&A. Okay, so lines are now unmuted, so feel free to let Allie know of any questions. And Richard was kind enough to post a link up into the public chat about the implicit bias, so thank you so much for that, Richard. And Allie, thank you so much for that really comprehensive presentation. Congratulations on that legislation being passed. I very much hear you about now some of the implementation work is very hard, but not to sell short the incredible work you and your team did getting that legislation passed.
Thank you. Yeah, it really was a coordinated statewide effort. I don't want to make it sound like it was just me or the OUNCE. I mean, here at the OUNCE, we had two, I partnered so much with our two registered lobbyists, and then our early childhood advocacy sphere here in Illinois is really collaborative, and so there were just tons and tons of organizations that helped work on this, and so it was a team effort.
And I saw a few folks trying to put something into the chat. Any questions, thoughts, anything? We still have some time. Okay, Richard has a question. So he's giving us a little bit more information about the tool. And yes, and I don't know if anyone had mentioned the child, but that's another tool that is under review right now from Walter Gilliam. Thank you for adding that in, Richard. Any questions for Allie or for Catherine while we are lucky enough to have them on the line? I mean, I think they both can really speak to what it takes to or even, at different stages, but when thinking about your system and where infant early childhood mental health consultation could fit. If anyone has any questions or wants brainstorming, now is an opportunity.
and I'm just going to advance the slides here so that you can see the contact information for the OUNCE and myself if you have any questions. On our webpage, we have an advocacy page, and we have just kind of more examples of what we do. I didn't talk as much about our advocacy work. We have an Early Childhood Advocacy Day we organize every year in Springfield. We do a lot of grassroots Advocacy 101 training for providers, home visitors, families, kind of how do you talk to a legislator about early childhood, things like that. We have advocacy toolkits. We have legislator lookups. So you can find all of that on our website.
Great. Thank you so much for that, Allie. Other questions? Look forward to chatting with everyone again in a couple months. So thank you so much for your time, and enjoy 20 minutes back into your day.